Hi, everyone, and welcome to Fit for Fellowship, a survival guide for the first-year general cardiology fellow. I'm Megan.
I'm Stacy.
And welcome back. So our speaker for today is Dr. Megan Kamath. She is a heart failure and transplant physician at UCLA and received her medical degree from the Northeast Ohio Medical University School of Medicine. She completed her internal medicine residency at Summa Health System before going on to complete a fellowship in cardiovascular disease at the Allegheny General Hospital. She then went on to pursue a further subspecialty fellowship in advanced heart failure and transplant cardiology from UCLA School of Medicine, where she is currently attending. And we look very much forward to her lecture on the complications of transplant. So let's dive right in.
Hello, my name is Dr. Megan Kamath, and I am one of the advanced heart failure and transplant cardiologists here at UCLA Health. I'm pleased to present the topic today of introduction to transplant, and I hope that this is useful as you begin your careers in cardiovascular medicine. We will cover quite a bit today, including a definition of advanced heart failure as a background for why transplant medicine is needed. We'll cover orthotopic heart transplant or OHT history, some data from the ISHLT, evaluation and listing for OHT, desensitization, immunosuppression, rejection, including treatment algorithms for cellular and antibody-mediated rejection, and we'll end with infection post-transplant and post-transplant care. So let's get started. As you can see from the schematic in the middle of your screen, there are several different definitions for advanced heart failure. The key things to remember are when you're seeing a patient who has severe symptoms despite optimal medical therapy, recurrent hospitalizations, and severe functional impairment, it's important to consider a referral for advanced heart failure therapies. When we in heart failure talk about the severity of a patient's current illness, we go over their ACC stages, their NYHA functional classes, as you can see in the middle of the screen, and the Intramax profile of the patient, as you can see on the right side of your screen. We follow a algorithmic type of approach to these patients, and this includes things like reversible causes being excluded, making sure that the patient has tried optimal medical and/or device therapy if that's applicable. And if the patient still has cardiogenic shock, hypoperfusion, or worsening end organ function, despite all of these things, then we would refer to an advanced heart failure center for an evaluation for advanced heart therapies, including temporary or durable devices and/or heart transplantation. The mnemonic "I need help" can be really helpful in thinking about when should one refer a patient to an advanced heart failure center. On the left side of your screen in blue, you can see both absolute and relative contraindications to heart transplantation. Absolute contraindications being systemic illness with a life expectancy less than 2 years or fixed pulmonary hypertension. And you can see there are several relative contraindications to transplantation that need to be addressed on an individual case-by-case basis. Let's go over now the history of heart transplantation. In 1967, the first human-to-human heart transplant was performed by Dr. Christian Barnard. The patient survived 18 days and, however, succumbed to pneumonia. In January of 1968, Dr. Norman Shumway performed the first U.S. heart transplant at Stanford. This was a Life magazine cover you can see on the left from September of 1971 that talked about the tragic record of heart transplant. And on the right side of your screen, you can see the pictures of the two pioneers of human heart transplantation, Christian Barnard on the left and Dr. Norman Shumway on the right. What were some of the challenges to transplantation in those days? Well, there was certainly an inability to diagnose rejection histologically. It wasn't until the 1970s that we had the development of an endomyocardial biopsy. There was a lack of preservation methods, and that led to significant cold ischemia times. There were legal and ethical considerations. It wasn't until the 1980s that the UNOS, United Network for Organ Sharing, was formed. There was maybe limited recognition of which opportunistic infections existed and how to safely prevent those. And now we have safe and effective prophylaxis strategies. And there was also a lack of long-term survivors due to an inability to halt acute and chronic rejection. As you can see, Cyclosporine was FDA approved in 1983, and tacrolimus was FDA approved in 1989. Let's go over some data from the International Society for Heart and Lung Transplantation. While the number of patients with advanced heart failure continues to increase every year, the number of adult and pediatric heart transplants has remained relatively steady over the last 30 years. Most patients that are being transplanted are transplanted for the indication of non-ischemic cardiomyopathy or ischemic cardiomyopathy, with many smaller percentages of patients being transplanted for other diagnoses, for example, congenital heart disease, hypertrophic cardiomyopathy, or even something like retransplantation. When we talk about survival post-OHT, you can see that survival has improved tremendously over the last several decades. This is probably due to a combination of better patient selection, as well as overcoming some of those challenges to transplant that we discussed in some of our previous slides. Let's go over now the OHT evaluation process. As you can see on your screen, it takes a village. This is a picture of our UCLA heart transplant team. When we evaluate a patient for heart transplant, it not only includes a clinical history and physical examination, but also laboratory evaluation and further imaging as well. We also would include things like a right and left heart catheterization, cardiopulmonary exercise testing, age-appropriate malignancy screening, and equally important, psychosocial evaluation and financial screening as well. This is a UCLA evaluation protocol, and I just want to note as well that we often obtain additional consults depending on each patient's specific history. When we talk about the very important psychosocial component of evaluation, we talk about the combination of psychopathology, adherence, neurocognition, substance abuse, and social support. And we discuss all of these things in a multidisciplinary advanced therapy selection meeting in the context of the patient's medical and surgical risk, as well as their frailty and nutrition status. Let's talk a brief moment about cardiopulmonary exercise testing. So when we talk about exercise testing, it's really important to know that there are certain cutoffs that should be used to guide listing. So for example, in patients that are intolerant of a beta blocker, a cutoff peak VO2 of less than 14 milliliters per kilogram per minute should be used to guide listing. In the presence of a beta blocker, a cutoff for peak VO2 of less than or equal to 12 milliliters per kilogram per minute should be used to guide listing. So it's really important to know what your patient's initial treatment has been so that you can use the right cutoffs. Let's go through UNOS listing criteria. So this is a little bit of a busy slide, but it goes through the most updated UNOS listing criteria from October of 2018 to the present day. So you can see we have 6 different statuses. Status 1 being the highest urgency for transplantation, to status 6 being the least urgency for transplantation. And there are several different criteria for each of these statuses. So status 1 includes those patients like VA ECMO or non-dischargeable surgically implanted biventricular support devices or mechanical circulatory support devices with life-threatening ventricular arrhythmias. Status 2 includes those patients, for example, with an intra-aortic balloon pump, or those patients who have a MCS device with a malfunction, or a percutaneous endovascular mechanical circulatory support device. Status 3 is usually your bread and butter hospitalized patient on inotropic therapy, as well as encompasses some of the mechanical circulatory support patients with complications, and also our dischargeable LVAD patients get a discretionary 30 days of status 3 time after implantation. Status 4 refers to those patients who are on inotropic therapy without hemodynamic monitoring, dischargeable LVADs without their discretionary 30 days, different types of amyloidosis or restrictive or hypertrophic cardiomyopathy, or even retransplantation can be considered in this. And certainly congenital heart disease is also included in status 4 as well. Status 5 is candidates that are on the wait list for at least one other organ at the same hospital. And status 6 refers to all adult candidates who are suitable for transplant. So this is just a framework to get you started. And certainly as you get more involved with advanced heart failure rotation, to become more familiar with this, you'll notice that we may often have patients with an exception for the status, where we have petitioned the regional review board to suggest that a patient may be sicker than what their assigned status would be, and we believe that they deserve a higher status listing, and then you may see some slight modifications based on that. So just to go over this in a little bit greater detail, as I said, status 1 is the highest urgency for transplantation. Status 2 certainly includes your patients that fall right below that status 1 highest urgency. And then status 3, as I said, is your bread and butter multiple inotrope or single high dose inotrope type of patient that you would see in your coronary care unit as well. And again, here status 4, 5, and 6. Status 7, I should note, is for those patients who are deemed temporarily inactive for a multitude of reasons. So now let's go to immunology and transplantation, and this will be a brief overview. So when we talk about immunology, we talk about both innate immunity or rapid response immunity and adaptive immunity or slow response immunity. During the course of an adaptive immune response, memory T and B cells are generated, which allow us to have a more rapid and effective response to reinfection. This is an important concept because immunologic memory is what allows vertebrates to survive in a world where we are re-exposed to pathogens throughout the lifetime. When we talk about adaptive immunity and generating memory, you can see that memory is generated after the primary infection, and you can see upon re-exposure that memory is quite helpful. When we talk about antigen receptors, we're talking about genetically rearranged clonal receptors that bind to antigen that is displayed on the major histocompatibility complex molecules on antigen-presenting cells. And you can see a schematic of this in the middle of your screen. The major histocompatibility complex, also known as MHC, is a genetic complex coding for cell surface proteins to help our immune system recognize foreign substances. We also talk about HLA, or human leukocyte antigens, that are coded within the MHC. So class 1 HLA is expressed on all nucleated cells, and they present antigen to CD8 T cells. Class 2 HLA is expressed on B cells, dendritic cells, and monocytes, and they present antigen to CD4 T cells. You can see on the picture in the middle of your screen there as well, this is a typical HLA matching report that you would get, where we would compare the heart donor and we would compare the recipient, not only looking at blood type, but also HLA matching as well to understand whether this would be a suitable match for the donor recipient pairing. When we talk about T cells, as I mentioned on the previous slide, we talk about CD4 T cells and CD8 T cells. CD8 T cells are cytotoxic T cells that directly mediate the immune response, and they release perforin, causing direct lysis of infected host cells. CD4 T cells modulate the activity of other B and C T cells. They help to both stimulate the immune response, helper T cells, or suppress the immune response, regulatory T cells. When we talk about DSA, that refers to donor-specific antibody. And these are formed by the immune system when you are exposed to proteins that appear similar to tissue types. Sensitization is thought to occur as a result of exposure to foreign HLA. This can be via several different mechanisms, things like prior transplantation, pregnancy, transfusion, human tissue allografts. That includes things like cardiac valves, pericardial or dural patches. And other risk factors can include ethnicity, viral infections, influenza vaccine, and ventricular assist devices as well. It has been studied that in patients with LVADs, or left ventricular assist devices, platelet transfusions have actually been associated with the development of class 1 antibodies, whereas transfusion of red blood cells, especially if they're leukocyte reduced, has a much smaller effect. When a patient is sensitized, that is certainly higher risk because sensitization is associated with post-transplant mortality, including graft loss, rejection, and coronary artery vasculopathy. We also talk about panel reactive antibodies, or PRA, and this refers to a group of antibodies in a test serum that are reactive against any of several known specific antigens in a panel of test cells or purified HLA antigens from cells. And essentially how this works is recipient cells are exposed to random cells of the donor population to give us an estimate of the risk of acute rejection. This PRA score is then expressed as a percentage between 0 and 100%. And when we talk about sensitization in thoracic patients, we talk about a PRA threshold of anywhere between 10 and 25%. We also talk about a calculated PRA, which is based on antibody specificity, and that's computed from HLA frequencies amongst donors in the United States. It's an ethnically weighted database and actually looks at the percentage of actual organ donors who express greater than or equal to one of the unacceptable HLAs. So for example, if you have a patient who has a calculated PRA or a CPRA of 80%, you would expect that they would be incompatible or not able to accept an organ from about 80% of those donors. And so although the CPRA threshold for sensitization in heart transplant is not well established, most centers use a CPRA of 50% to define sensitization, and some consider 75 to 80% the threshold to perform desensitization. And we'll get into that on the next slides as well. When we think about when to desensitize, as I said, we think about what is a patient's CPRA. If the CPRA is less than 20%, usually you can get the patient transplanted without needing desensitization treatments. If the CPRA is between 20 and 50%, you definitely have to monitor for DSA after transplant and certainly monitor for rejection. But if the CPRA is greater than or equal to 50%, we know that that's associated with increased wait time and wait list mortality or potential need to remove a patient from the wait list. So this is when we would consider desensitization therapy. What types of strategies are there to desensitize a patient? Well, as you can see on your screen here, there are several. One might consider therapeutic plasma exchange and IVIG and rituximab, therapeutic plasma exchange, IVIG and rituximab, therapeutic plasma exchange and bortezomib. And there are certainly new agents, as you can see on the bottom right side of your screen, which are currently being studied or used in smaller numbers of patients. We particularly at UCLA have used several of these agents, but it's really important to consider the desensitization strategy for each patient on an individual basis. As you can see, not only is the mechanism of action slightly different for each of these agents, but also the immune effects are different and the major adverse effects are different too. And so therapy needs to be very personalized in this type of situation. Let's talk now about immunosuppression. So as you can see here, with the advent of immunosuppression has come a longer survival post-transplant. When we talk about induction therapy, we talk about intense prophylactic therapy that is used at the time of transplantation based on an empiric observation that more powerful immunosuppression is needed to prevent early acute rejection. What are some of the agents that we might use? Things like Anti-Thymocyte Globulin or ATG, Basiliximab or Simulect, and Corticosteroids. Let's go over each of these agents in slightly greater detail. So ATG or Anti-Thymocyte Globulin is a polyclonal antibody product that targets multiple receptors on T cells. This is important because it causes complement-mediated cell lysis and T cell depletion. The most important thing in these patients are to monitor for infusion reactions such as fever and chills, thrombocytopenia, leukopenia, infection, malignancy, and even anaphylaxis. And it's important to caution if used in patients with a rabbit allergy or a history of serum sickness. Basiliximab or Simulect is an anti-IL-2 monoclonal antibody against CD25 on activated T cells. We often see this used for heart-kidney transplants or as part of a renal sparing regimen. And the most important things to monitor are for hypersensitivity, infection, and malignancy. Some clinical pearls here are that no pre-medications are necessary, and use of basiliximab usually allows us to do a more slower up titration for our tacrolimus therapy. Corticosteroids, the mechanism of action is blocking of cytokine expression. It impairs monocyte and macrophage function and decreases number of circulating CD4 T cells. There are several side effects to corticosteroids, as you're probably familiar with, but those can include hyperglycemia, hypertension, ulcers, hyperlipidemia, edema, acne, and osteoporosis. Also notably, we use corticosteroids in conjunction as first line for acute rejection treatment as well. As a reference, I've put on the right side of your screen different glucocorticoids and approximate equivalent dosing. When we talk about maintenance immunosuppression, this refers to less potent prophylactic therapy that is used throughout the lifespan of the transplanted organ to prevent late acute rejection and improve graft survival. Our mainstays of therapy here are calcineurin inhibitors, our antimetabolites, our mammalian target of rapamycin inhibitors, and corticosteroids. So calcineurin inhibition, as we said, is today's backbone of therapy. It prevents intracellular signal transduction by inhibiting calcineurin and results in a lack of IL-2 production in the face of immune stimuli. You can see the mechanism of action here for tacrolimus and our usual starting dose. And a key clinical pearl is to make sure that you know the timing of the administration of this medication, because otherwise your trough levels will be inaccurate. Further clinical pearls, as you can see on the right side of your screen there, the IV to PO conversion, that you can give it IV as a 24-hour continuous infusion. You can do sublingual tacrolimus, and that African-American patients may require higher doses due to the CYP3A5. Tacrolimus, we often dose by goal trough levels, and you can see that as we go further and further out from transplant, the goal level reduces. It's important to also know that tacrolimus have several drug-drug interactions. So if a patient is on another medication concomitantly, it's really important to know if that's going to affect their tacrolimus level or not. Cyclosporine is also one of our calcineurin inhibitors, It was more commonly used in the early 1980s prior to the introduction of tacrolimus, but sometimes for certain reasons you may see us use cyclosporine for patients even today. The important things to monitor similar to tacrolimus are for nephrotoxicity, hypertension, hyperkalemia, hypomagnesemia, neurotoxicity, gingival hyperplasia, and hirsutism. And the IVPO conversion is about 1 to 3. Again, here, just for reference, the goal cyclosporine trough levels for different stages post-transplant. Let's talk about mycophenolate mofetil. So the Cellcept or mycophenolate mofetil inhibits inosine 5 monophosphate dehydrogenase, and this is a rate-limiting step in the de novo synthesis of guanosine nucleotides, and this is essential for DNA synthesis. The dose that we normally use starting out is 1,000 milligrams PO twice a day, and it's a 1-to-1 IV to PO conversion. When we think about adverse effects or things that we need to monitor for, nausea, vomiting, diarrhea, abdominal pain, bone marrow suppression, and malignancy are big things that you want to be aware of. Clinical pearls for this drug, you want to hold it or consider holding during active infection. There is a extended release formulation called Myfortic, which has less GI side effects, and you want to separate it from other medications, for example, the magnesium by greater than or equal to 2 hours. And this is a black box warning for congenital malformation. So if a female patient's post-transplant is considering pregnancy, this would be a medication that you would need to stop. Azathioprine, likely one that you may not come across as commonly because mycophenolate is just more commonly used. And certainly the things that you want to monitor when you are giving somebody azathioprine is for bone marrow suppression, pancytopenia, hepatotoxicity, rash, fever, chills, and malaise. Let's talk about sirolimus or rapamune. So the mechanism of action of this medication is that it inhibits the mammalian target of rapamycin, which inhibits the cellular response to cytokines and prevents the advancement of the cell cycle from G1 to S phase. The indications for using sirolimus, most commonly, if we're trying to limit calcineurin inhibition-induced renal dysfunction, if there's an intolerance to calcineurin inhibition or mycophenolate, if we want to delay the progression of coronary allograft vasculopathy, or if there is a history of cancer. Adverse effects to monitor for hyperlipidemia, edema, hypertension, anemia, thrombocytopenia, leukopenia, delayed wound healing, mouth ulcers, pneumonitis, and pulmonary fibrosis. This is one that you want to hold surrounding procedures and thinking about particularly wound healing. And the half-life of sirolimus is usually about 60 hours. So that's also another thing to consider as well. Everolimus or Zortress, also a mammalian target of rapamycin inhibitor, and common things to look out for: delayed wound healing, leukopenia, anemia, thrombocytopenia, edema, hypertension, nausea, and the half-life of everolimus is about 30 hours. So when we talk about supportive medications, this can include an anti-infective prophylaxis and cardiac allograft vasculopathy or CAV prophylaxis. So anti-infective prophylaxis encompasses cotrimoxazole or Bactrim for 12 months post-transplant, valganciclovir or ganciclovir for 3 to 12 months post-transplant, fluconazole for cocci-endemic reasons, and clotrimazole and nystatin for 3 months post-transplant as well. When we talk about vasculopathy prophylaxis, we're talking about aspirin and statin. Let's talk about rejection now. Acute cellular rejection is a primary form of transplant rejection. And it's important to note that antibody-mediated or humoral rejection also contributes to morbidity in transplant recipient. So biopsy evidence of rejection is usually present before other signs and symptoms of myocardial compromise develop. Cardiac transplant rejection can be asymptomatic And so that's where routine surveillance biopsies truly had become the mainstay of early detection and treatment of acute rejection. When we talk about grading for cellular rejection, we talk about 0, 1, 2, or 3R. And 3R being the most severe with diffuse infiltrate on histology with multifocal myocyte damage and edema, hemorrhage, or vasculitis. When we talk about risk factors for rejection, that includes things like age, ethnicity, donor-recipient HLA matches, female recipients and donors, and the time from transplant as well. When we talk about antibody-mediated rejection, the true incidence is unknown, and it's been reported in the literature anywhere between 3 and 85%. So as you can see, a wide range there. Risk factors can include elevated PRAs, ACMV positivity, prior mechanical circulatory support needs, retransplantation, multiparity, a positive T-cell flow cytometry crossmatch, and certainly women have tended to have a higher incidence of antibody-mediated rejection as well. When we talk about grading for antibody-mediated rejection, again, we talk about grade 0, 1, 2, or 3, with 0 having negative histologic and immunopathologic findings, and grade 3 having severe histopathologic findings of interstitial hemorrhage, capillary fragmentation, mixed inflammatory infiltrates, endothelial cell pyknosis, and or karyoxis, and marked edema. So this is from the International Society for Heart and Lung Transplant that talks about findings in acute antibody-mediated rejection of the heart. And that includes things like a clinical evidence of acute graft dysfunction, histologic evidence of acute capillary injury, immunopathologic evidence for antibody-mediated injury, and serological evidence for anti-donor antibodies. So you can see it's a combination of findings that leads us to diagnose antibody-mediated rejection here. Biopsies have been the gold standard for rejection monitoring, but more recently in transplant medicine, the focus has been on profiling gene expression in circulating white blood cells in order to identify early changes in the immune system that correlate with rejection. Specifically here, I'm referring to Allomap blood tests and the AlloSure blood test, which AlloSure refers to the donor-derived cell-free DNA. This schematic here shows acute rejection. On the top left of your screen, you can see mild cellular rejection with focal lymphocytic infiltrate. On the top right of your screen, you can see severe cellular rejection with dense lymphocytic infiltrate, myocyte necrosis, and disruption of the myocardial architecture. In C, you can see antibody-mediated rejection with endothelial swelling, macrophage infiltration in the capillaries. And in box D on the bottom right of your screen, you can see the C4D stain as well, okay? C4D deposition. I'm including these algorithms for cellular rejection treatment so that you can begin to get a sense of the things that we do once we define that a patient is in rejection. Certainly a lot of these treatments depend on whether there's allograft dysfunction or not, and the severity of the rejection. For antibody-mediated rejection, it's really important also to assess for the presence of donor-specific antibodies by flow cytometry and follow very, very closely. And you can see here this schematic for antibody-mediated rejection based on the biopsy positivity for C3D and C4D. When we talk about rejection, we also want to make sure we think about the time course of rejection. That includes hyperacute rejection, which occurs within minutes of implantation. And this is usually due to complement activation and preformed antibodies. The treatment for this is really retransplantation, although there also needs to be great attention paid to preventing this, making sure that, for example, the crossmatch is reviewed, that there's ABO compatibility, and reviewing the PRAs as well. Acute rejection can occur at any time. The highest risk, though, is usually in the first 3 to 12 months post-transplantation. As we talked about, it's mediated through T-cell activation, and prevention is the goal of our current immunosuppressive therapy. Chronic rejection can occur in the months to years after transplantation timeframe. It's usually mediated through humoral immune reactions and antibodies directed against vascular endothelium. And the treatment ultimately for this is usually retransplantation if the patient is a candidate for that. Acute rejection usually manifests as acute graft dysfunction, meaning that from a heart perspective, there's decreased cardiac output. Chronic rejection has a more insidious presentation, and this is often referred to as chronic graft vasculopathy. And the hallmark is increased fibrosis in the vasculature of the transplanted organ. For the heart, this is referring to aggressive coronary artery disease in the transplanted organ. When we talk about coronary artery vasculopathy, we talk about risk factors being transplant associated, as well as our traditional classical risk factors as well. Things like hypertension, hyperlipidemia, obesity, tobacco, and diabetes. And this leads us to, in conjunction with inflammation and endothelial cell injury and dysfunction, this leads to the development of cardiac allograft vasculopathy, or CAV. When we grade CAV, we grade it on a scale of 0 to 3, and 0 being non-significant, grade 3 being severe. With severe cardiac allograft vasculopathy, we're talking about an angiographic left main greater than or equal to 50%, or greater than 2 primary vessels greater than or equal to 70%, or isolated branch stenosis in all 3 systems greater than or equal to 70%. Or grade 1 or grade 2 with allograft dysfunction, meaning an LVEF of less than or equal to 45%, or evidence of significant restrictive physiology. You can see in this schematic here the different ways that we would invasively evaluate for coronary artery vasculopathy. On the left, at the top, you can see our coronary angiograms, and on the right at the top, you can see intravascular ultrasound, or IVUS, demonstrating LAD intimole thickening. And on the bottom of your screen, you can see our intracoronary flow studies that show the FFR for this patient. When we talk about surveillance and management, again, it's a combination of evaluating for risk factors, evaluating for inflammation, endothelial injury and dysfunction, and trying to manage or address all of those potential risk factors in the post-transplant patient. Let's talk for a moment about non-invasive monitoring for rejection. When we talk about gene expression profiling, or you may have heard the test called Allomap, we talk about recirculating peripheral blood mononuclear cells that can reflect earlier host responses of those at the local sites. The measurement of these cells' gene expression provides useful diagnostic information because certain genes and immune pathways are up or down regulated prior to allograft infiltration and injury. The gene expression is detected by microarray analysis of RNA from the peripheral blood. And it is important to note that there's a very high negative predictive value, meaning that this test is very good at excluding rejection. So if you have a normal Allomap, you can be very, very certain, 99.6%, that you're excluding rejection. The study that looked at gene expression profiling with the Allomap test was the CARGO-2 study. And it showed that Allomap score variability can predict the probability of adverse events within 3 years after the last gene expression profiling score. When we talk about AlloSure, we talk about a clinical grade targeted next generation sequencing assay that measures SNPs to actively quantify donor-derived cell-free DNA. It's being studied currently in the heart transplant population, although it had been previously validated in the kidney transplant population as well. Let's now focus on infection post-transplant. The infection risk depends on the transplant recipient's epidemiological exposures, as well as what we like to call their net state of immunosuppression. Epidemiological exposures refers to donor-derived infections, recipient-derived infections, nosocomial infections, and community infections as well. When we do an infection risk assessment, we do a donor screening, a recipient screening, and an overall risk assessment for the donor-recipient pair. Let's review a timeline for infection. So when a patient is less than 1 month out post-transplant, we think about infections with antimicrobial resistant species, things like MRSA, VRE, Candida, things like aspiration, catheter infection, wound infection, anastomotic leaks and ischemia, or even C. diff colitis. We think about specifics for donor-derived infections, which are relatively uncommon, but also recipient-derived infection via colonization as well. When we talk about the 1 to 6 month time period, we talk about whether the patient has been effectively prophylaxed. And so different risk for different infections exists depending on the prophylaxis that each patient has received. And then when we talk about greater than 6 months post-transplant, we would talk about things like community-acquired pneumonia, UTIs, late viral infections, as you can see below. And it's really a combination of looking at the risk of the donor-derived infection, the recipient screening, and the time course. Where is a patient post-transplant? How far are they out? What other risk factors do they have? Early infection after solid organ transplantation is often related to either pre-existing conditions or a complication of surgery. And bacteria and yeast are the most frequent pathogens in the first 30 days post-transplant. It's notable that greater than 50% of bacterial infections occur during the early post-transplant period. And this includes things like superficial and deep surgical sites infections, as well as anastomotic leaks. Intermediate infection, as we talked about, most often related to latent pathogens. Classic opportunistic infections present during this time. And this is the peak time for CMV without prophylaxis. But it's also important for us to remember during this time period, EBV-associated post-transplant lymphoproliferative disorder, PCP, and toxoplasmosis as well. Late infections greater than 6 months post-transplant are usually related to other underlying comorbidities. For example, things like diabetes and malignancy can increase the risk of late post-transplant infections. The mortality with infection is the highest for fungal infections, followed then by protozoal, bacterial, and viral infections. So let's now talk about the post-transplant patient. When we monitor a patient post-transplant, immediately post-transplant, that is, we talk about a post-operative 12-lead EKG, right atrial or CVP monitoring, measuring their cardiac output, doing an intraoperative transesophageal echocardiogram, doing invasive arterial pressure monitoring, left atrial or wedge pressure monitoring, arterial oxygen saturation monitoring, and a continuous assessment of urinary output as well. This guideline comes from the ISHLT. So it's really important that we monitor closely the assessment of biventricular function, cardiac output, and MVO2, because RV failure can be common, so we've got to look out for it. We may need to consider in the immediate post-transplant period inhaled nitric or prostacycline therapy to enable selective pulmonary vasodilation. These patients post-transplant are usually epicardial paced to 90 to 110 beats per minute, And it's important to know that when a patient has primary graft failure with an unknown cause, early temporary mechanical circulatory support should be considered if there's no response to inotropic support. Longer-term considerations include management of other comorbidities, things like hypertension and diabetes, which can be common side effects of our immunosuppressive medications. And also surveillance is important for conditions like osteoporosis and malignancy, given long-term immunosuppression as well. And with that, I will end and be happy to take any questions at our live Q&A. Thank you so much for your attention, and please feel free to reach out to me if there's anything that I can further explain or answer.